Oh iya. Langsung.
Yeah.
Cek 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 satu.
Tes, tes.
Excellencies, distinguished guests, participants, ladies and gentlemen. Assalamualaikum
Assalamualaikum
warahmatullahi
warahmatullahi wabarakatuh.
wabarakatuh.
Peace
Peace
be
be
upon
upon
you.
you.
Good morning, and we are delighted to welcome you to the Zoom online meeting for the opening ceremony of the first International Conference on Public Health and Medical Science 2021, hosted by University of Malahayati, Bandar Lampung, Lampung, Indonesia, coordinated with Higher Education Service Institute 2, LLDIKTI 2, with the theme
The
The
world
World
in
in
COVID-19.
COVID-19.
The Honorable, the Head of Higher Education Service Institute 2, LLDIKTI 2, Professor Yuliansyah SE, M.S.A, Ph.D.
The Honorable Rector of University of Malahayati, Dr. Achmad Farich, Dr. M.M.
The Honorable Dean of Faculty of Medicine, University of Malahayati, Dr. Tony Prasetya, SPPD, FINESEM.
The Honorable Dean of Faculty of Public Health, University of Malahayati, Mrs. Sriyanti, SP.M.Kes.
The Honorable all keynote speakers, Professor Albert M. Hutapea, MPH, AIFM, AIFO from the University of Advent, Indonesia. Associated Professor Dr. Akil R. Patil, Associated Professor Dr. Akil R. Patil, MBBS, MD from SMBT, India.
The Honorable Parallel Presenters, the Honorable Organizing Committee members, and all distinguished guests, participants of the first International Conference on Public Health and Medical Science 2021.
Excellencies, distinguished guests, participants, ladies and gentlemen. Thank you very much for coming on the second day of the first International Conference on Public Health and Medical Science 2021. It's the first conference conducted by University of Malahayati, coordinate and collaborate with Higher Education Service Institute 2, LLDIKTI 2, to accommodate exchange of theories, information, and research among experts of public health and medical science.
Ladies and gentlemen, without further ado, now please help me welcome our keynote speech, Professor Albert M. Hutapea, MPH AIFM AIFO from the University of Advent, Indonesia. The keynote speech will be moderated by Mr. Slamet Widodo M.Kes. For Mr. Slamet Widodo M.Kes, please come forward to open the session.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. As the name of the committee, in the second day, actually, I want to say so sorry for having trouble with the technical condition because we have many screens in this case, especially regarding to my screen, there is trouble with the internet connection. So I suppose that it will not decrease our interest, our focus on this conference. Okay, thank you for Prof. Albert for joining this meeting. And before starting our presentation session, actually I want to introduce my valuable presenter or keynote speaker we have today, Professor Dr. Albert M. Hutapea, M.Ph. AIFM AIFO. He is currently serving a full-time professor at Department of Pharmacy, Faculty of Science, University of Advent, Indonesia. And then he received his Bachelor of Science in Biology, Biomedical, and Master of Public Health degree in Human Psychology from the Department of Psychology, Faculty of Science, Method, University, Bangkok, Thailand. And many things about information about Prof. Albert, actually, we will send the profile to all the participants or audience and also for the presenters on this conference. Before starting this presentations, I want to tell to my professor, Prof. Albert, you have time, start from now, maybe not from at 10 now, but at 10:16. You may start your presentation in 40 minutes, and there will be around 10 minutes for our question and answer sessions. So welcome to Prof. Albert for your presentation. Thank you.
Hello, everyone. Good morning. I suppose it's my turn to speak now. I'm thankful to the committee who has invited me to share some lights on the lessons learned from the COVID-19 pandemic. That's a competitor. It's all right. That happens. All right. This pandemic has given us a lot of troubles and a lot of lessons to learn if we talk about it positively. So what I'm going to present to you is a topic that might be interesting to almost everyone in this pandemic. Allow me to share the screen, please. So the title is Lessons Learned from the Coronavirus Pandemic. What are these lessons that we have learned from the coronavirus pandemic? You know, we can learn any lesson from any event in our life, whether the event is positive or negative, whether the event is beneficial or troublesome to some of us or to all of us. Lessons learned. All right. Values may change because of the pandemic. Values may change. We're going to see a dozen of lessons from this pandemic. But lesson number one is that people now realize they have to think seriously what are the things that are important or unimportant in their lives. They become selective. They have more time to think about it. They have more time to meditate upon it. But people actually really begin to reevaluate their lives and assess their priorities. What became priorities during the pandemic may not be the same priorities before the pandemic. People began to reevaluate their own lives. Now, they also have realized that the precious life, they have to enjoy despite the pandemic. And they began to appreciate the small things in life, little things that they didn't enjoy or they didn't have time to enjoy before the pandemic. Now they have learned to enjoy. And people are becoming more aware of their indebtedness to their family. They become more aware that the family is important. They become more grateful for family and friends. And during the pandemic, people realized that they miss social interaction. And sometimes they took things for granted, such as just a little hug, coffee with friend, chit chat with friends face to face. They miss that. Why? Because we are all social beings. We are all social beings. And the pandemic also has taught us to reach out, trying to reach out. Why? Because when we are secluded in our own homes, working from homes, very little interactions with our fellow beings, then there is that big realization that actually talking to other people is also important and a very important component of social life. So we have been taught to reach out. And we begin to realize that human-to-human connection is really crucial. It's really crucial. It's very important because it's a very important component of the social life, our social life. And now people begin, this is part of lesson 1, people begin to realize that people closer to them deserve more of their time and attention, and vice versa. That's why they now have really longer time to meditate upon the importance of these people who are closest to them, either friends, family, or relatives. Now, I'd like to focus a little bit on family. Now, people begin to realize that family really matters. When people, especially in the big cities, when they work and they have these hectic schedules in their lives, they sometimes neglect spending time with their families. Now, when the pandemic comes, either afraid of being sick from the coronavirus, then will end up in cemetery. Now people begin to realize what really matters is what really important is the family. And sometimes we read probably in newspapers or in news, we heard that the daily confinement brings a lot of troubles, because some people even joke, that what is this separations of families, even divorce rate is higher during the pandemic. But even then, more people began to realize what family truly means to every one of us. Now, people in the family, they want to be with their families and their relatives because they are being secluded. We can see this in the Mudik session, Mudik, when people go back to their own villages, even if there was a very strong restriction from the government not to travel out of town or to another town, but people, they try very hard to escape, to break that rule. That's why the COVID rate has increased incredibly. Just a moment, please. I'm sorry about this. The battery of my laptop, I didn't realize that battery of my laptop is decreasing. Just a moment. Sorry. Very sorry about this. All right, I'm back. Sorry about that. Sometimes this technology can be distracting too. So family, more people now realize the importance of family. In fact, in America, there is a report in America that from February to July 2020, 2.6 million young adults moved back with one or both parents. Oh, America is a country where once you reach 18, then you're expected to get out of the house and then be on your own. But here, over there, people began to realize that family is very important. That's why from February to July, it's a matter of what? How many months is this? 4 months, 4 to 5 months. 2.6 million young adults moved back with one or both parents. They miss their family. So family really matters during this pandemic, and more people realize that. And now there is also a report saying there is also a report saying that couples, long-term couples with long-term relationships, they have better relationships during the pandemic because it's very important. Relationship is very important. Human relationship is very important. Now, technology really helps. If, for example, a grandmother or grandfather cannot hug their granddaughter in person, then they can tell stories through FaceTime, through video call. And these video calls are getting cheaper now because of the technology is getting cheaper too. And because of the technology, then families can be connected with emails, even WhatsApp text, even WhatsApp calls. And this connection between the older generation and the younger generation is really beneficial to both parties. You know, the older ones are not, the older ones do not feel secluded, and the younger ones think that they are being cared for, and they learn some wisdom from the older generation. Then the older people are really afraid of being secluded. You know, they're afraid of being isolated. They're afraid of being disconnected from their young ones, from their children, and from their grandchildren. That's why technology helps, and people begin to realize that family is very important, especially during this pandemic. Now, the second lesson that we learned from this pandemic is that there is a loud wake-up call to the medical world, very loud call to the medical world, that they have to improve whatever efforts they have in finding new methods, finding new medicines, finding new vaccines in meeting these challenges of this coronavirus pandemic. Now, we have heard about these mRNA vaccines, you know, like Pfizer and Moderna. They use messenger RNA technology for that. And we have learned that mRNA vaccines, what mRNA vaccines really are, they are specific molecules, okay, that stimulates the cells in our body, yeah, to trigger specific immune response to fight that very disease that's being vaccinated for against. That's mRNA. And we have seen countries produce these kind of vaccines, Now, people say that, well, we are so thankful that this mRNA vaccines technology will help us in the future, especially in a place where there is this need of need of flu shots, like in the area where they have winter season, when the prevalence of this flu is very high. Many people opted to be vaccinated with flu vaccines, and they're hoping that someday they'll have these flu vaccines that will last for years. They are hoping, and the medical world is working on that. Not just like the flu vaccines, but any virus that might attack us. Okay, and also the medical world now is trying harder to produce, okay, mRNA products that can cure diseases that cannot be cured with drugs, cannot be treated with drugs. And it is believed that doctors will be able to sequence tumor so that with this information from the sequence in tumor, then a vaccine can be created that will vaccine created from that particular tumor will be effective in triggering the immune system to fight that particular tumor. And also, it is hoped that messenger RNA vaccines will prepare human beings for future pandemics. So there's a big promise offered by the medical science, and they have heard that loud wake-up call from the sufferings that people are having during these pandemics. What about lesson 3? So lesson 1 was people begin to realize what is important. Lesson number 2 is medical world is rising up to meet the challenge of this pandemic. What about the third lesson? The third lesson is self-care is not hedonism. Some people think that it is waste of money, waste of time in taking care of yourself. Some people think of that as hedonism, pleasure seeking, pleasure seeking. And it is very important. Self-care is very important for your own well-being and for the well-being of those people around you. This self-care concept is very important. Nurses will really understand what a self-care is. Self-care is taking care of yourself. Okay, taking initiatives in taking care of yourselves. There is this very recent European survey done, and they found out among the British respondents, that 77% of British respondents aging 75 or younger, 75 years or younger, they really consider it very important to have self-care. They consider, so 77% of the respondents in Britain, they believe that self-care is very important. It is their own responsibility to take care of their own health instead of relying too much on the healthcare system to take care of you. Because some people think that because they have insurance, they have good healthcare system, then it is not their responsibility to take care of their own health. Some people think that way, especially in the area where health insurance is mandated, is compulsory. It's okay. Hospital will take care of me when I get sick. But now, during the pandemic, there is a reversal of this thinking. There is a reversal of this thinking. People begin to realize that they have to take care of their own health. Even hospitals cannot help you sometimes, you know, when you have reached that level where you are beyond redeemable, where you are beyond curable. Not all people who enter hospital will come out of the hospital alive. I have some friends who suffered from COVID. They brought this friend of mine, you know, one particular friend from Jakarta to Bandung, and the saturation level, the oxygen level was already 40. What? I said, and he didn't make it. I'm very sorry for that. People begin to realize that you have to take care of your own health. And the rest that you cannot do will be taking care of the medical staff in the hospital and so on. People begin to realize that self-care is important, not just hedonism. That is lesson number 3. What about lesson number 4? This emergency, this pandemic, you know, this pandemic has taught us that we always have to be ready for emergency fund. People lost their jobs. People lost their jobs. Their business is deteriorating. I mean, their business is dying. They need money for the family, for food, basic necessities, even for medicines. When they are not ready with emergency fund, then they are in big trouble. That's why now people begin to realize that everyone must be ready with an emergency fund. Yeah, emergency fund. Fund that should not be touched when the condition is not an emergency one. Fund that should be stashed away. Okay? Okay. And how do we have this emergency fund available? There are so many ways. Some people have to force themselves, you know, some people have to force themselves to set aside some of their salary, automatic payroll deductions. This is a key to success. No matter what, you have to set aside some funds for emergency. Emergency. For special contingencies, you know, you have to do that. Sometimes people, especially during pandemic, not all people can lend you some money. Not many people, because everybody has an increased need for funds during this pandemic. That's why people began to realize that emergency savings is very important. An amount of money reserved for emergencies only. Okay? And the other reason why we need to have this emergency fund is because we do not know when the next crisis will be. We are not, some people say medical technology, medical science will help us live better. Friends, don't forget that hospitals, they are more on the curative side of disease management. And a more important side of taking care of health is in your hand. Try to stay away from any habits that will encroach on your health. So still, more crises will come. I'm very sure of this, because we don't know if this is RNAs, these viruses, you know, these viruses have mutated and so on, and they will bring new crises. Now we have Delta variant coming. Oh, everybody's worried about that. What about the other variants? They're more coming, but they're still being isolated in some countries. Like in Brazil, there is a new variant of this virus. So we really do not know when the next crisis will strike. We have to force ourselves to have an emergency fund. Sometimes we say, oh, I don't have enough money to save. We have to save some money, to set aside some money for emergency funds. Little by little, in Indonesia, we have a saying, Sedikit demi sedikit, lama-lama jadi bukit, you know, little by little, and you can build a hill. If you translate that to English, ya, little by little. Tak terasa itu, ya, tak terasa. Makanya ada celengan. Oh, that's why you have that celengan, you know, because little by little, then you can build a hill, as an Indonesian saying. You don't feel the pinch, just a little bit. Save a little bit every month from every income. If you don't have monthly income from any profit that you make from your profit, from your business, then you have to stash aside a specific fund for emergency fund. That was about emergency fund. What about lesson number 5? This is getting serious now. Comorbidity matters more than age. Now the victims of this pandemic, you know, this COVID, are young ones too, not only the old ones. Many young ones, those who did not take care of their health. They have comorbidities, either diabetes, even diabetes now, younger people are getting diabetic, you know, even hypertension. Younger people are getting hypertensive, and so on, and so on, and so on. Comorbidity matters more than age. It doesn't mean that when you are younger, then you have better immune system, then you have more chance of surviving the pandemic than the old ones. People have learned this lesson now. We have learned this lesson, that age poses a high risk, but comorbidities poses a much higher risk. Commodities. Bottom line, take care of your health. Let's see the specific statistics, you know. Risk for a fatal infection is 4 times higher for healthy people 25 years old and older than for all participants younger than 65. But comparing this 75 and older, okay, when they have chronic health conditions, then the risk is 13 times higher. This is another interesting statistic. You know? A healthy 75-year-old is 1/3 likely to die from coronavirus as a 65-year-old with multiple chronic health issues. So even if you're younger, but if you have comorbidities, then you have threefold of probability that you will die from coronavirus. So old age doesn't matter. It's the comorbidities that matters. So the bottom line is age affects the risk of severe illness with COVID. So let's avoid chronic health conditions. Take care of our health. Who is more responsible in taking care of our health? We ourselves have or hold more responsibility in taking care of our health. That's why there's a rise in this lifestyle medicine, you know, because people begin to realize, even in the medical world, medical doctors, they are turning into lifestyle medicine. See, because lifestyle changes can improve overall health. Thus, when we improve our overall health, then we reduce our risk of developing severe COVID or dying from COVID. Some people with COVID have different way their bodies react to the infection. Some people get by with very mild symptoms, and some people die very quickly because the symptom is very severe. How is that? How? Because of their health conditions, especially if they have comorbidities. Okay. Then, in May 2020, last year, there was a report from a British study, a study of 387,000 109 adults in their 40s to 60s. So ages from 40s to 60s, they found that there is a higher risk of 38% for severe COVID in people who don't exercise regularly. As simple as a walk in the morning, daily walk in the morning, can spare your life or can ease the symptoms of COVID if COVID finally catches up with you. Yeah, I myself got COVID about 2 months ago, but then the symptoms are very mild, very mild. Okay, because yeah, God is merciful, of course, but because I have done my best in taking care of my health. So your habit of having regular exercise should be considered as a vital sign. Now in lifestyle medicine, they don't just measure your temperature or your blood sugar or your blood cholesterol. There is one parameter that they measure, and this is in lifestyle medicine, because I'm teaching that subject, lifestyle medicine. That what about your habit of exercise? They have a number for that, whether you're doing well in that matter or not. Just like when they measure your temperature, whether temperature is normal or not. Okay, they have standard for exercise, whether you're doing it enough or not. Okay, yes. So lesson number 5 is very important for us because it concerns our health and our ability to survive this pandemic. That is, remember this, friends, comorbidity matters more than age. Lesson number 6. Technology literacy is a must for older people. Yeah, I have a friend, older teacher. He is now 68, I think. Well, when he was still active teaching, he could not even operate his own cell phone, to send texts. He always asked his assistant, please send this message to this, send this message. So I asked him, why don't you do it on your own? He said, come on, I'm lazy to learn that. It's okay. It's a new technology. In Indonesia, we call it gaptek. No, older people must learn new technology. Yeah, they must learn because it is this technology that will enable them, to survive better. Now, this is a lesson learned during this pandemic. Then technology literacy is a must. Okay. Before the pandemic, these older people, they buy fruits at the grocery store. They go to the store, check the fruits. They have to hold the fruits. Sometimes they have to smell the fruit before they decide to buy. Okay, that is before the pandemic. Older people do that. Now, they are not free to get out of their homes. They have to learn to buy even fruits online. Yeah, before the pandemic, when you buy shoes, you have to try the shoes on before you decide to buy, whether to buy or not. Now, you cannot just go because even the malls are closed, have closed down. Even the malls have closed down. The big shops have closed down. You have to rely on technology to buy new shoes now. That was before the pandemic. You have to go to the store. Now, before the pandemic, they have their doctor measure the blood pressure. Now, with this technology, we'll learn later. There's a lesson in telemedicine. Now, the doctors can even check your physical condition remotely. Yeah, look at this picture. The doctor is talking to her patient remotely, virtually. And that is possible now. Technology make it possible. Even now, with the technology, a doctor in America can do operation here in Indonesia with the use of robots. Robots. The movements of his hands in America is done exactly the same to the very accurate, the most accurate level to these robots. That's possible now. So even older people must have this technology literacy. Now, during the pandemics, what? They have to what? To use technology even to connect with their loved ones. To continue to stay alive, they have to rely on technology. They cannot just go to the store and buy something in the store because there is a high risk for the older people to contract COVID. Okay, next. Now, these older folks, the older people may know the technology, but there is a difference between knowing how to use and preferring to use. I know how to do it, but I don't want to do it because I don't like to do it. That's different. Okay? Why? Because older people, sometimes they are allergic to new technology. Now, even toddlers, babies, they can they can operate a handphone, to watch YouTubes or something in the handphones. Toddlers can do that now. Okay. So in many cases, telemedicine will be more effective. Telemedicine. We'll talk about that later, more about that later. Now, lesson number 4 is that people can work anywhere as their office, at home. They can work at home. Many people now work at home. Of course, they enjoy because they travel less. So millions of workers and their managers, they realize now, they have learned that they can be as productive as they were in the office, especially if they work with laptop only. We're not talking about mechanical machines. No, these workers who use laptop as a tool in their office, they can bring the laptop anywhere and then work from there as if that place is their office. Yeah, they can be as productive as that. Why? Because they have now video conferencing, high-speed internet, and other technologies. They have that. And so people can work remotely out of the office, but they work productively. Now, people, because they do not have to stay close to their office, which is especially in big cities, they can live, they can buy a house or stay in a home far away from the cities because their home has become an office. Cheaper. They can live cheaper in suburban areas. They can do that. And now, in many offices, I'm sure that attendance, before the pandemic, attendance is a must. You have to be present physically in your office to be considered present. But now, not anymore. Not anymore. So workers are not strongly attached physically to their office or workplace anymore. No more hassles. No more sitting in traffic to and from work. You don't have to travel from your home to your office. People learn now, because of the pandemic, that people can work anywhere as their office. Okay? What about that? Just for a single meeting, you have to fly hours. For hours, you have to fly. No more. So this, you can have a worldwide meeting with attendants from many parts of the world right at your home because of the technology. So with this internet connection, people need, because they are working from home, then they won't complain if they have to work longer hours because they're at home anyway. Yeah. All right. Now, but there is another part of the lesson learned, because some employers are replacing the older workers, the higher paid workers than the young ones. Okay, they are trying to replace the older folks, the older workers than the young ones. Less pay, but more, but technologically more adept, the young ones. But when you compare the older workers with the young workers, each of these two groups have their own specific advantages they can offer to the office. The older workers, they have better communications and interpersonal skills. And this is very important when you work remotely, because you are not present with your subordinates. No, you're not with your subordinate physically. You have to have the spatial skills in communication. And that that's better communication and interpersonal skills belongs to the older generation. Now, lesson number 8. Now we begin to realize that we do not need as much as we think. We do not need as much as we think. We have learned to live simply, learn to live very simple conveniences, okay? We don't have to have flashy cars because we are working from home, okay? What we need now is, during this pandemic, only foods, clean water, good health, that's all. That's all, and those can be considered luxuries now. But that's what we need. We have learned to live simply. We have to live simply. Okay. Thus, people begin to think that they have to prioritize, to rearrange their priorities in life. What is more important? Now, the most important thing now is to take care of your health. What about lesson number 9? Lesson number 9, there is uncertainty in this pandemic. Uncertainty. Will I get that COVID or not? Will my family be safe? What about the government policies? We keep on changing about these isolation policies, this PPKM, we call that in Indonesia. Okay, the limitation of people's movement from one place to another place. We're talking about cities here, from intercities movements. Keep on changing. People become say, what is the next? What is the next policy will be announced? People become uncertain. What will happen? What will happen? Okay. We really do not know when. When the normal condition will return. We cannot control the situation. Even the advanced countries, they have difficulties in controlling the pandemic. What about those countries that do not have a very strong control system? Probably, but in countries they have strong control systems, then the pandemic is easier controlled in those countries. Now, but what we can do is, the lesson is the lesson that we learned from this pandemic about this living with uncertainty is that we just have to teach ourselves to react differently. We have to react differently. It is not the stress. Stress is not what happens. Stress is what we react to what happens.
So sorry, Prof. Albert. You still have 10 minutes left.
Yes, thank you.
Okay.
For the talk, right? 10 minutes for the talk or question and answer?
For the talk.
Okay, yes. Don't worry. This will speed up from 9 to the next lessons. Yes. So with this uncertainty, we have to learn. We have to learn to control what we think. We have to learn our attitude toward these uncertainties. Okay. What about this healthcare? Even before the pandemic, our healthcare system would not promise a very good service. During the pandemic, this has been 3 descent, even worse, So when the pandemic came, a disaster has become a catastrophe. Yeah, catastrophe, yeah. So we have to learn that we cannot return to the old ways. What about now lesson number 10? Now, people will gather differently, and they will gather, people try to stay away from one another, except those living in one house. Okay, the crowding will be different, and it is different now. Yeah, look at these people here in the park, they have circles that only people with living the same home or same or whatever the group is, they're all grouped. So crowding will be different. Sometimes we think that we need to gather to watch concerts, in big crowds. That's what we long for after being isolated for more than 1 year now. Yeah, but crowding will be different. People will gather more carefully. Okay, they will be careful about the spaces that they maintain between them and the other people beside them. Okay, for example, if they think that eating in a closed restaurant, a closed door restaurant, is not safe, that people prefer to eat outside, outdoor. Okay, so lesson number 11. Lesson number 11 tells us that loneliness hurts health more than belief. Loneliness, being isolated, especially the older people when they are old. Well, in Indonesia, the older ones live with their children. But in other countries, like in America and European countries, the older ones are separated. Many of them are separated from their families, from their children and grandchildren. Now, this pandemic has taught us a lesson, another lesson, that loneliness hurts health. A report says that people with dementia are dying. Okay, they are being isolated to protect them, and yet they have higher probability for dying because of being isolation. Here, this is a statistic from America. During the 5 months of the pandemic, 13,000 people died, more than the previous year, in nursing homes. Why? Because their nursing homes are being locked down. Families and relatives are not allowed to visit them. The primary purpose was that to protect these old ones, the older ones. And yet this protection itself killed them. Yeah, this protection itself kills them. It killed them. Because now people begin to realize that loneliness hurts health more than believed earlier. Okay, now 56% of adults aged 50 plus say that felt isolated in June 2020. And this number is double than what happened in 2018. People become lonely when there's during this pandemic. Okay. Okay. Now, the older ones feel very happy when they can meet the younger ones and share their wisdom, share whatever they have to share. This human-to-human interaction is beneficial to health, even not only for the older ones, but also for the young ones. All right, lesson number 12. This is very obvious, that nature is more spacious than our homes. Yes, nature is a medicine in itself. Yeah, green space, nature in our surroundings will keep us healthier because we have that better mental conditions in nature than in crowded cities, even so in homes, Okay, so we can prove this by saying, by going for a nature walk, even poking our head, out of the window to our lawn, will bring a different kind of sensation. Yeah, we'll feel better for that. Look at that. Isn't that beautiful? Just sit there. Look at these mountains and this open space. Then we'll have less stressful life, because outdoor spaces reduce stressful life events, improving memory and meaning and happiness in older people's lives. Not only in older people's lives, in everyone's life. Open space. Try as much as possible. This is the reason why Puncak is always crowded, during weekends in Jakarta. people from Jakarta, they always try to go to Puncak, you know, that creates a lot of traffic jams. Even videos at home, you enjoy nature videos and sounds, record sounds of nature. That brings some benefits to our health, you know, listening to recordings of nature like crickets and so on and so on. Now, lesson number 13. Yeah, we still have a few more minutes. There is a rising gap between rich and poor in any society. Some people are blaming the vaccine producers. They say, oh, they're getting richer. So what? We need those vaccines. Yeah, there is gap, inequalities. Yeah, wealth inequalities between the rich and poor. The rich getting richer and the poor getting poorer. And this is a lesson that we have learned from this pandemic. Okay. Now, are we brave enough? Are we bold enough, courageous enough to have a different system where the marginalized people with different colors, different religions, different social status can live together? Yeah, because those factors do not determine the attitudes, the way they treat to other people. Now, the telemedicine will go very quickly here. This is the last one of last second. Telemedicine. Yeah, there is a proof. People begin to realize there is that there are indisputable benefits of telemedicine. You consult with your doctors through laptop, through handphone, and so on and so on. They have this now Allo Doctor, and so on and so on. That is part of the advancement of this technology, you know. So people, even with chronic conditions, they can consult their doctors through handphones and through Zoom meetings and so on and so on. Okay, the last lesson. Our cities will never be the same, for sure. Yeah, our cities will never be the same. Things will change in our cities. Crowds used to be the enemy. Now crowds are the enemy. We don't want to be in a crowd. Cities will be changed, no? And then public buses and subways. Whoa, this is a health risk. Try to avoid that as much as possible. People will advise you. What about crowded office towers? Oh no, let's work from home. You know, cities will change. What about suburban homes? Homes that are away from the city are more preferable now. That is where what we want. Okay? Yes. My timer has said I have to stop. Well, thank you, Hemant, very much. Mas Slamet, I hand this back to you.
Thank you very much for your nice, interesting, and valuable information about what should we learn from pandemic COVID-19. So actually, our activity today is the result of learning in pandemic era. We can conduct international conference using Zoom like this moment, and we can greet many friends from the other countries, such as many friends from India and another country maybe, and also from around the world using our YouTube channel, Prof. Talking about this presentation or this nice conversation, talk with your topic, there is questions, and I want to accommodate the questions from the audience. You know that at this moment, telemedicine grows up, and Indonesia, maybe we have like Allo Doctor and others, but you know the consequence of this telemedicine. For example, if there is a doctor or medical practitioner get in touch on this service and they do like malpractice maybe, so is there any regulations? I mean, because when we do the practice, real practice in the clinic, we have the certain regulation. So how do you think of if there are some doctors or maybe health workers in the telemedicine do malpractice, maybe misunderstanding in giving prescriptions and others? So is there any special regulations or maybe our IT regulations from our government? That's I accommodate from the question from Pak Samino, my friends from Malahayati University. Thank you, Prof.
All right, that's a very good observation. If you ask me if there are regulations that will regulate that kind of practice, I really cannot answer you. But because this is a new development, but the government must be very keen in producing regulations, policies that will protect the people. Yes, there might be possibilities. Yeah, in telemedicine, probably there will be some unintended malpractice, I should say, accidents. I call that accidents.
Yes,
Who will be responsible? The government has to be responsible if things go uncontrolled. They have government. I think the government will take care of this. They'll issue some policies and some regulations. I'm sure the government is working on that. I'm very sure of that. Yeah. Yes. That's
so,
like.
No, so how do you think of Medical Council of Indonesia, maybe, or maybe the ED? Is there any regulation regarding to this telemedicine? If we give this condition to our government, we know that we have IT regulation. It is so flexible how to enrich many people to the jail. But you know that for telemedicine, it is like many startups in our condition at this moment. If there is lack of data, only giving like how can I say here, never go to the jail.
Yeah, actually, we don't have to worry about that. Let the government take care of that. It is their responsibility. If I'm a lawmaker, then I'll take care of that. If I'm a lawmaker, I'm not a lawmaker. So, yeah. But I believe, I have faith in our government. I have faith. I trust them. I'm sure they're looking into this seriously, just like the online business, you know.
Yes, there is like online business because there is just every doctor when we see. So sorry, I state the name. Allo doctor maybe. There is a specialist and general doctor. Automatically, there will be different charges for every consultation. Consult with the doctor.
Well, there is no free lunch. Yeah, every service must be compensated. Well, compensated normally. Yeah, it must be compensated. So, but the people must be protected through regulations, and we just hope that the government is working well on this. Yes.
Okay, Prof. Albert, maybe I will give the chance for our audience. Perhaps if you want to have a direct question to Prof. Albert in this presentations or conference, you may raise your hand. Okay, I have our friends, Mbak Dwi will have question for you. Okay, come on, Mbak Dwi. Maybe our team is still servicing its technical. Hello, IT team. I need your help to give a mute Mbak Dwi to deliver her question for Prof. Albert. Yeah, wait a minute, Mbak Dwi. Maybe you can greet Prof. Albert.
Well, while waiting, I'd like to greet Dr. Akhil Patil.
Yeah, I see.
How are you, Doc? I'm happy to see you.
And also Mbak Dwi, say hello to you because still has problem with the mute. Because this condition, like our previous situation, now I'm on my place. It is really nice for me, but in starting our presentation, I sit in the control room. So it is not really enjoy for me, but now I'm very enjoying this situation. And it happened to with Mbak Dwi. They and also Dr. Pachil cannot give or deliver the question. Maybe still have problem with the technical condition. Hello,
Yes, the
IT.
host can change the setting. You know,
Yes, still is in setting.
I'm not the host, so the host can change the setting so that the participants can unmute themselves.
Yes. So we need the help of Mas Agung. Maybe hello, Mas Agung. Hello. Hello, Mbak Dwi.
No, still unmuted.
Prof, we have 104 participants in this, include us in this conference. Every time it will increase because with the different time, especially from India. Oh, we have trouble with the technical.
The host, who's the host?
Yes, the host. Wait a minute, Prof.
I think Mbak Dwi is typing her question.
Hello. Good morning, Prof. Albert.
Oh, you're on now. Okay, right.
Yes. Good morning, Prof. Thank you very much. Yes, thank you very much for your wonderful speaking, Prof. So it's very interesting. My question is, Prof, during this pandemic, give so many impact, not only to us as a employee, as a student, and also to particularly for poor people. In this situation, as we know that they get so many suffer, right, for this situation, so many restriction from government. So in your opinion, what they have to do to maintain their mental during this pandemic, and also what they can learn from this situation? Only that one, Prof.
Thank
Thank
you,
you.
Mbak. Thank you so much. It's a good question.
Yeah,
Yes.
regarding to the people movement, there is limitation on the people movement. We know, especially in Jakarta, maybe there is a level 1, 2, 3, 4, and how to differentiate. Actually, we're really confused about this strict regulation, but maybe Prof. Albert has solution how to give advice to the mental and behavior our people in Indonesia.
And also, yeah, what they can learn also from the
Yeah.
situation. Yes, thank you, Prof.
Yes. Mental condition is very crucial. I mean, it has a big contribution to your immune system. I have observed that. That's why when someone told me, "Oh, I'm already positive," you know, my antigen test said that I'm positive, I need to go to hospital. I said, "No, don't go to hospital." Why? They'll take care of me. No. When you go to hospital, if you can still manage yourself, or people can still take care of you at home, don't go to hospital. Why? Because when you go to hospital, you see people die on your left, another people die on your right, and that you will ask yourself, "Oh my, when is my turn?" When someone begins to think that he is hopeless, then there will be no hope in him. So mental condition is very important. Self-talk is very important. I always tell people who told me, you know, I'm positive now. I said, no, think positively. Okay, you'll survive. You will survive because death rate is only about so and so percent, 5%, the max. Don't worry. You will survive. When you believe you will survive, you'll survive. There was this brother of my colleague, you know, his mother, they shared a room because they could not go to hospital because no more bed in the hospital. So they stay home. The mother died. I mean, they brought to the hospital finally, but the mother died in the hospital. So the son said to his sister, Mom has died. So my turn is next then. After he said that, the next 2 days he died. He's still young because he believed that he would die. So mental state is very important here, very important. We have to tell people. That's why I'm so fed up with the media, and I'm so fed up with the media. They only focus on the death rate. What about the survival rate? Oh, this has survived, this has survived. You know, our media should be full of that. Not picture of people dying, people lining up. No. We are telling people to die fast through the media. And I don't like that. That's why I turn off TV. I don't like to watch TV, even before. But now I only watch TV for news. Now I don't watch news anymore because it's only about death, about death, about death, about death. I don't want to crowd my mind with very negative thinking. So if you want to stay up, I mean, if you want to keep your immune high, do not rely too much on vitamins. Yes, vitamins contribute, of course, vitamins and mineral supplements, they contribute, but greater contribution comes from the state of your mind. Yes. So tell the media people to stop telling about death in the death rate. Oh, sekian orang mati, you know, this many people died, this many people died. No, they should focus on, oh, you know, people survive. Look at this, they survive. Oh, these people survive. That will increase the hope in people who listen to the news. People say, oh, I have negative, I will die. Let's help people with that. When you have friends who have contracted COVID, tell them you will survive. You will survive. Your body is very strong, you will survive. Unless he has comorbidities, then do not promise him too much, but tell them you will survive. Well, that's just my opinion about that. No.
Okay, thank you, Prof. I do agree with you because many media today only having like provocation, maybe I can say here, bad informations and others, especially in social media, yeah, include formal media also. But yes, this condition, we need, like you say before, that we should have good literation maybe in digital. But many people in the world still has problem with this literation. Okay, we can talk more with these informations, but we have a limitation of time, Prof. Albert. Maybe.
Mas Slamet,
yes.
There is a very important question for Dr. Vijay here.
Yes, actually, how to give alliterations for uneducated, because, you know, at this moment, many people, not only in India, but in Indonesia also, still have problem with this condition. They don't believe to the COVID-19. So, is there any special tips or how we can educate them?
Use media, because I think everyone now has cell phone. Use media to give positive messages. The government should be more
change the method.
Yeah,
the government should change the method
to send the health educators to go to the underprivileged people. Some people joke to me, you know, I say, look at those crazy people. No crazy people get COVID, you know. these people who roam, the homeless ones, they don't get COVID. I say, are you sure? Are you sure? Because they're not covered by the media. You don't know. You don't know for sure. Don't tell me that crazy people. He's just joking. Say, if you want to stay healthy, if you want to stay away from COVID, be crazy. No. So the government should be more intense in giving health education. Mas Slamet is a health educator, I heard. He's a health promoter. You have to work hard. You have to work hard, Mas Slamet.
Okay, thank you, Prof, from your nice sharing and caring with us. So sorry because the limitation of time, we still have next agenda, and so sorry for all the audience who the question, we cannot accommodate all the question, but don't worry, we will share this material to all the participants. Once again, thank you very much for my beloved Prof Albert for joining this conference. And we can conclude that many studies or lessons we can learn from COVID-19, like Prof. Albert said, such as from telemedicine, and then how we should avoid crowding and others. Only maybe in Indonesia, we only apply 3M or 5M, but Prof. Albert give more than 5. That's 15 tips of how we can learn from COVID-19. Again, I say thank you very much for your nice sharing and caring, and to all my nice audience. I think that's all our sessions for these presentations, and I will back to my Master of Ceremony. Thank you.
Thank you. Thank you so much.
Okay, thank you for Professor Albert M. Hutapea for the keynote speech. And we would like to ask you to stay on the screen because we would like to present the ceremonial gift to you for sharing your expertise in this session. And to present the ceremonial gift, kindly be invited the Vice Rector 1, Mr. Muhammad Eskam MM. Okay, and now we will hold a photo session. The keynote speaker, the Vice Rector 1, as well as participants are welcome to take a position.
Ladies and gentlemen, we would like to invite to the place to deliver his keynote speech Associated Professor Dr. Akhil R. Patil, MBBS, MD from SMBT, India. The keynote speech will be moderated by Mr. Slamet Widodo, MKes.
Ladies and gentlemen, please welcome Associated Professor Dr. Akhil R. Patil, MBBS, MD, and Mr. Slamet Widodo, MKes.
Okay, well, good morning, Dr. Akhil. Maybe in
Thank you
India,
for the,
still morning.
Yeah, good. It's still good morning.
Okay.
So good morning and namaste.
Namaste.
Thank you for the introduction.
Namaste. Okay, actually here we want to introduce our the last keynote maybe in this conference, Dr. Akil, as he is the practitioner doctor from India, affiliate with SMBT India, and he is now as a practical doctor also in the hospital of SMBT. So Dr. Patil will tell us about how to conduct medical, how to have like a clinical practice in COVID-19 from India. And we can give insight from this presentations, and of course this information will give us a new site or maybe new knowledge or new informations we can learn from Dr. Patil's materials. Okay, Dr. Patil.
Hello, sir.
Hello.
Thank you for the lovely introduction.
Okay, sorry. Before starting your presentation, I want to give you information that you, like Prof. Albert also, you have 40 minutes, sorry, 40 minutes.
Yeah, 40 minutes.
Your presentation, and then there will be 10 minutes for question and answer session. And for all audience or participants, you can write down your questions, and later after these discussions, I will accommodate your questions. Okay, for you, time is yours, Dr. Patil.
On behalf of SMBT Medical College and myself, I would like to thank all the organizers of this conference. Thank you very much. So, can I share my PPT here?
Yes.
Are you able to see this PPT, sir? Hello? Hello?
I can see your slide.
Yeah, you can see the slide, right?
Yeah.
Okay, so for last 2 days, you must be hearing a lot about this COVID-19. So I doubt that there will be anything novel, like novel COVID virus we have. So today I'm going to speak about the clinical management of COVID-19 in India. So what is this problem related to COVID-19? So if we look at the statistics worldwide, we have nearly about 22 crore patients suffering from total number of cases of COVID. There is a mortality of approximately 45.5 lakh population has died because of COVID infection. Where does the India stand? So we stand rank 2 as far as the total number of cases, with 3.3 crore cases in India. The mortality is stands rank 3rd as far as the individual countries are concerned, with 4.4 lakh mortality because of COVID. But if you consider our population, so this number is still lower as compared to the world statistics. So we have per million 24,000, approximately 24,000 mortality per million. Number of cases, and mortality is still lower. It's only 322 per million as compared to the other countries who have who are extensively affected because of this infection. So this may be because of an innate resilience in Indian population towards many infectious diseases. And second one is we have an excellent healthcare facility, though it is an unorganized healthcare system we have, but still we cater to a majority of population with excellent medical facilities in our country. So what is this COVID virus? Sorry. So we all know it's because of SARS-CoV virus type 2. It's an zoonotic origin virus related to bat SARS-CoV virus. First case was detected in Wuhan, China on 31st December 2019. India had its first case on 27 January, approximately 4 weeks later. WHO confirmed COVID as a pandemic on March 2020. This virus has a structure of a core of genetic material surrounded by an envelope with spike proteins. This gives an appearance of crown. In Latin, corona means crown, so that's why it has its name as coronavirus. It's fairly a novel strain of coronavirus. It's a zoonotic origin. It is an enveloped RNA beta coronavirus. It utilizes ACE2 receptor on for cell entry on affected organs. The median incubation period is approximately 5 days, ranging from 1 to 14 days. The most infective period is usually 2 days prior to development of symptoms to 7 days after development of symptoms. There are two ways of spread: person to person. From infected person, it can spread to its contacts, or with direct contact with the contaminated surfaces by fomite route. Which are the tests for detection? So nucleic acid amplification test like RT-PCR and rapid antigen detection test, and radiological investigation like chest X-ray and HRCT can be performed for diagnosis of this disease. The chain of infection starts with the virus. The reservoir is usually the people and animals who are infected with the COVID virus. They may not be symptomatic, or patient may be seriously ill. So the portal of exit for the agent is usually from mouth and nose. This occurs while talking, coughing, sneezing. So modes of transmission are usually from person to person, airborne route, or direct contact with contaminated surface. The portal of entry is usually mucous membranes of nose and mouth of the recipients, and susceptible hosts are usually non-human persons. In fact, there is no such as non-human person. Everyone is at risk who are in contact with this virus. So pathophysiology says that it's predominantly patients usually present with upper respiratory tract infection associated with SARS-CoV-2 infection. Very small proportion of these patients usually progress to more severe stage of disease characterized by a dysregulated immune response, hyperinflammation, and acute respiratory distress syndrome. Histopathology, based on the postmortem findings, says that the endothelial damage of pulmonary vasculature, then there is microvascular thrombosis, extensive alveolar and interstitial inflammation, and pulmonary intravascular coagulopathy. All this leads to something called as ventilation perfusion mismatch. So along with ventilation perfusion mismatch and acute respiratory distress syndrome leads to hypoxemia. This hypoxemia in turn activates the coagulation pathway, and this vicious cycle repeats and deteriorates the lung damage. So how the patient presents clinically? So ICMR, which is the institute which guides the management of COVID in India, has given case definitions based on WHO guidelines. According to it, the suspected case is any person who meets the clinical and epidemiological criteria. The clinical criteria includes an acute onset of fever and cough, or an acute onset of any three of the following symptoms like fever, cough, generalized weakness, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea, or altered mental status. Epidemiological criteria consist of any person residing or working in an area with high risk of transmission within the previous 14 days prior to symptoms, or any person residing or had a history of travel to an area with community transmission within previous 14 days, or any person working in any healthcare facility within the community within last 14 days or prior to the symptoms. Second suspect category is a patient presenting with severe acute respiratory illness, which is characterized by an acute respiratory infection, history of fever or measured fever of more than 38 degrees Celsius, cough with onset within the last 10 days, or patient requiring hospitalization. So these were the subset which are considered as suspect cases. The probable case is a patient who meets the clinical criteria and has a history of contact with a probable or confirmed case of COVID-19. Any person who is suspected case with chest imaging suggesting COVID infection, a person with recent onset loss of smell and loss of taste sensation without any identifiable cause, or death in a patient presenting with respiratory distress whose death was not otherwise explained, and patient had a history of contact or with probable or confirmed case of COVID-19. This constitutes patients with probable case of COVID-19 infection. A confirmed case is a person who has tested positive for a nucleic acid amplification test like RT-PCR or any other test which was approved by ICMR. A person with positive SARS-CoV-2 antigen test. These are rapid detection test for COVID infection, and who was in contact with probable case definition or suspect criteria, or an asymptomatic patient who has positive with rapid antigen test and who is a contact of probable or confirmed case of COVID-19. So these are the cases who are confirmed as COVID-19 infected patients. So clinically, patient presents with symptoms with general symptoms like cough, fever, chills, sweats, difficulty in breathing, headache, body aches, tiredness, anorexia, nausea, vomiting, and certain specific symptoms like diarrhea, altered mental status, anosmia, and ageusia. What are the risk factors? So most common risk factors are age more than 60 years. So majority of elderly people were at the high risk of developing severe disease. Along with it, the underlying non-communicable diseases like diabetes mellitus, cardiovascular diseases, hypertension, coronary artery disease, chronic lung, kidney, and liver disorders, then cerebrovascular diseases, and obesity. These are the high risk for progression of this disease to severe cases. So clinical management, the patient are managed as per the ICMR guidelines. Am I audible? Hello.
Okay, you may continue your presentation.
So I was audible previously.
Okay, there is something trouble maybe with the connection.
So I have been muted again.
Okay, is it okay? Dr. Akil?
Was I audible previously? Hello.
Yeah, we still okay seeing your slide.
Okay. So should I continue from here only? Hello.
Is that okay with your connection?
It's okay. I'm able to hear you right now. I was muted for some time, I think.
Okay, you may continue. Come on.
So I have to continue from here itself.
Okay.
So clinical management is guided by the criteria or guidelines given by AIMS and ICMR for management of COVID in India. So these guidelines are uniformly distributed to and cater to all of India. So these guidelines are followed throughout India. So these guidelines usually give how to divide patients according to severity of. Again, I have been muted. Hello.
Yes, we're still seeing your slide. Okay, continue. You may continue.
Yeah, but I'm repeatedly being muted. Okay. So the guidelines are followed according to the ICMR protocol. So these guidelines give how to differentiate between mild, moderate, and severe cases, and the facilities in which these patients need to be admitted, and the medical management of the COVID infection. So depending on the severity, it is divided into mild, moderate, and severe grades. The mild consists of those people who are presenting with uncomplicated upper respiratory tract infections with mild symptoms like cough, fever, sore throat, nasal congestion, malaise, headache, and clinically they don't have any respiratory distress or there is no hypoxia. These patients are usually admitted or patients are managed on home isolation basis or in COVID care centers. So moderate cases are those patients who present with pneumonia, but there are no signs of severe disease. The patient usually have dyspnea and or hypoxia, fever, cough. Saturation is between 90 to 93% on room air. Respiratory rate is more than or equal to 24 per minute. So these patients are usually admitted in dedicated COVID health centers. These centers usually have oxygen backup. Severe cases are divided into 4 clinical presentations. So first is severe pneumonia. This patient usually have signs of pneumonia plus one of the following, that is respiratory rate more than 30 breaths per minute, severe respiratory distress, or saturation less than 90% on room air. Second category is acute respiratory distress syndrome. So this patient usually have a short duration of onset after the insult. So patient usually present with chest imaging suggestive of bilateral opacities, which are not fully explained by effusion or lobar or lung collapse or nodules. Then there is an origin of pulmonary infiltrates because of respiratory failure, which is not fully explained by cardiac failure or fluid overload. So we have to do an objective assessment to rule out cardiac involvement using 2D echo. Next is based on the oxygenation impairment in patients. So this is usually an arterial blood gas analysis finding. So mild ARDS is usually PO2 by FiO2 ratio of between 200 to 300. Moderate ARDS is PO2 by FiO2 ratio between 100 and 200. And ARDS, severe ARDS is usually a PO2 by FiO2 ratio of less than 100 millimeters of mercury with PEEP of more than 5 centimeters of water. Next subset is patient of COVID presenting with sepsis. So according to surviving sepsis guidelines, that acute life-threatening organ dysfunction caused by dysregulated human host response to a suspected or proven infection, in this case, the COVID infection. So signs of organ dysfunction can be altered mental status, difficulty in breathing, low oxygen saturation, reduced urine output, tachycardia, weak or thready pulse, cold extremities and low blood pressure, skin mottling, laboratory evidence of coagulopathy, thrombocytopenia, acidosis, high lactate levels, and hyperbilirubinemia. The fourth subset is patient presenting with sepsis with septic shock. So along with the presentation of sepsis, patient may also have hypotension or persisting hypotension despite volume resuscitation and require vasopressors to maintain mean arterial pressure of more than 65 millimeters of mercury. And patient presents with serum lactate level more than 2 millimoles per liter. So all these severe patients are usually admitted in dedicated COVID hospitals. These are usually high-end hospitals along with ICU backup with ventilatory support. So coming to the management of mild cases, usually these patients are isolated first. This is the first step in controlling this infection. So this will restrict the spread of infection to other people. So usually this patient present with symptoms or mild symptoms at primary care center or OPD. Some patient also resort to telemedicine route. So this patient can be managed at home under home isolation guidelines, which are given by Government of India. Certain people who do not fulfill these criteria usually are admitted in COVID care centers or primary health centers or other hospitals which are catering to COVID infection. So the people who do not fulfill these criteria are usually elderly people or patients who are at high risk with multiple comorbid conditions. That's why these are patients are admitted in a COVID care center for observation. Home isolation people are usually advised to follow physical distancing, indoor mask use, and strict hygiene for control and preventing the spread of the infection. Usually patient requires symptomatic management with antipyretics and antitussives. Then maintenance of hydration using oral fluids. Patients are advised to do gargles and steam inhalation multiple times for relief of mild symptoms like throat congestion and nasal congestion. So patients are advised to do temperature and oxygen monitoring at home 2 to 4 times and be in touch with their treating physician for further follow-up, as well as if there is any deterioration in clinical state. So usually drug therapy is focused on symptomatic therapy with either paracetamol or non-steroidal inflammatory drugs. Then certain investigational drugs like ivermectin and hydroxychloroquine have been used in India and are still being used. We have quite a good response to hydroxychloroquine in mild cases. So inhalational budesonide can be used in people who have persistent cough and fever beyond 5 days from onset. Systemic steroids are usually not indicated in mild cases. Treatment of other comorbid conditions are to be treated as per their individual guidelines. So management of moderate cases, usually these patients are isolated in dedicated COVID health centers. Detailed clinical assessment for baseline parameters are done in these centers, and the monitoring is done for any deterioration of symptoms. So usually patients are treated with symptomatic therapy, adequate hydration. These people have mild desaturation, so oxygen saturation may be low. So these people may require oxygen support. The target saturation is usually 92 to 96%. In COPD, we have a lower set of 88 to 92%. Oxygen can be delivered by nasal prongs, simple face mask, non-rebreathing reservoir bag, high flow nasal cannula, or simple nasal cannula. Anticoagulation with either unfractionated heparin or low molecular weight heparin is usually started in moderate to severe cases. Anti-inflammatory or immunomodulatory therapy with steroids using either methylprednisolone in lower dose of 1 to 2 milligrams per kg in divided doses, or injection dexamethasone 0.2 to 4 mg per day for 5 to 10 days is prescribed to control the inflammatory part of this infection. So antibiotics should not be usually routinely advised unless there is a chance or suspected secondary infection is in picture. So antibiotics are to be chosen as per the local infectious guidelines. Awake proning is promoted in moderate to severe cases to improve the oxygenation of lung. Then control of comorbid conditions is another important factor in management of COVID, because we have experienced many patients with diabetes having uncontrolled blood sugar levels and also developing other complications like mucormycosis. So control of comorbid conditions was very important. So monitoring included clinical monitoring for work of breathing, hemodynamic instability, change in oxygen requirement, because this guided the requirement of further stepping up of oxygenation management with ventilatory support. So serial chest X-rays were done to monitor the involvement of lung, whether there is an worsening. If there is an acute worsening, HRCT is preferred. Otherwise, serial X-rays were preferred. Lab monitoring was directed towards monitoring of CRP and D-dimer. So it was performed 2 to 3 days. CBC, kidney function test, liver function test usually done on alternate days. Interleukin 6 levels were only done in patients who were deteriorating and had to take the decision for tocilizumab administration. So CBC with differential count was usually done every second or third day. Coming to the severe cases, usually patients were managed with supportive therapy, as in the case of moderate cases. So symptomatic management, management of euvolemia or maintaining euvolemia with fluid management. Then these patients had severe type of respiratory dysfunction causing severe depression in saturation. So these patients are usually initiated on oxygen therapy, starting with 5 liters per minute of oxygen, and it is titrated to target the saturation level more than 90% in non-pregnant and more, between 92 to 96% in pregnant patients. The patient who could not maintain the target SpO2 are usually then put on either high flow nasal cannula or non-invasive ventilation, or if these patients are not tolerating, then patient was intubated. So the criteria for intubation were like high work of breathing, NIV is not tolerated, patient has a hemodynamic instability, or patient has a mental altered mentation or multi-organ dysfunction. So conventional ARDS net protocol was used when patient is intubated. So this ARDS protocol is for lung protection. It directs to use low tidal volumes and low pressure support. The contact precautions for prevention of transmission to healthcare workers as well as other patients was undertaken. Anti-inflammatory drug, same as in moderate cases, with injection prednisolone and dexamethasone was initiated, and in fact this was the mainstay of therapy. Anticoagulation with unfractionated heparin, low molecular weight heparin. Whenever LMWH or low molecular weight heparin was contraindicated, like in cases of end-stage renal disease, we preferred unfractionated heparin. So monitoring was similar to what we did in moderate cases with serial chest X-ray and HRCT whenever necessary. Lab monitoring was actually stepped up. Hello?
Yeah.
I have been muted again.
Okay, come on.
Hello. Yes.
Hello. You may continue.
So,
you may continue.
Yeah. So management of that third category, like hypoxemic respiratory failure or ARDS, usually patients are started with face mask with reservoir bag with 10 to 15 liters of oxygen per minute, which provides an inspiratory oxygen of 60 to 95%. So high flow nasal cannula oxygenation can be used, or patients may require non-invasive mechanical ventilation. So NIV settings are usually pressure support or lower pressure support of 5 to 15 centimeters, tidal volumes of low grade tidal volumes of 5 to 7 ml per kg, peak of 5 to 10 centimeters, and FiO2 of 50 to 100%, titrated to achieve the target of saturation more than 94%. So high flow nasal cannula settings usually start with flow rate of 20 to 30 liters per minute and increase by 5 to 10 liters up to 60 liters, and FiO2 of 40%, titrated by 5 to 10% up to 100% to achieve the saturation more than 94%. So endotracheal tube intubation was done in those patients who could not tolerate the NIV ventilation, or who had an hemodynamic instability, or patient had an altered ventilation at the presentation. So mechanical ventilation using low tidal volumes, 4 to 8 ml per kg, lower inspiratory pressures according to ARDS protocol of tidal volume of 6 ml per kg, respirated between 15 to 35 per minute, PEEP of 5 to 15 centimeters of water, target plateau pressures less than 30 centimeters of water, and target saturation of between 88 to 95%, and partial oxygen pressure of 55 to 80 mmHg. Prone ventilation was promoted in almost all patients who had refractory hypoxemia in moderate to severe cases of COVID. So PO2, so refractory hypoxemia was referred to as a PO2 by FiO2 ratio of less than 150 with FiO2 of 60% with PEEP of more than 5 centimeters of water. So prone ventilation of 30 to 60 minutes cycles was performed in different positions. The next was management of septic shock. The first step of management was to recognize septic shock. So for this, we utilized surviving sepsis guidelines for detection of or suspecting cases of sepsis, like QSOFA guideline test to look for cases of sepsis. These patients are usually managed with fluid resuscitation with crystalloids like normal saline or ringer lactate with CVP monitoring. Then vasopressors and inotropes are utilized to achieve the target of mean arterial pressure of more than or equal to 65 millimeters of mercury. So this is mean arterial pressure cutoff. So use of appropriate antibiotics wherever necessary were used. Certain investigational therapy which came in during this pandemic was the remdesivir, which is an antiviral drug directed towards COVID. Recently, WHO has withdrawn this drug as a treatment of choice in COVID. But in India, we still prefer this drug because we had excellent results with remdesivir in moderate to severe cases, and we had good recovery in majority of severe cases with COVID. So usually this is given within first 10 days of onset of symptoms with moderate to severe disease requiring oxygen supplementation. So contraindications were usually the renal and hepatic dysfunction, then pregnancy, lactating females, children less than 12 years of age. Patients who were not on oxygen therapy were also contraindication for this drug. Tocilizumab was another drug which was directed towards controlling interleukin-6 related inflammatory process. So it was indicated in patients with presence of severe disease, and usually was given or preferred to be given within first 24 to 48 hours of clinical deterioration or ICU admission. The indicators for using this drug was significantly raised inflammatory markers like CRP and interleukin 6, and those patients who are not improving despite using adequate dose of steroids. For this, we needed to rule out active bacterial, fungal, and tubercular infections. Other drugs like itolizumab, bevacizumab have been used less frequently. Bevacizumab was FEGF growth factor inhibitor. So management of other complications like other comorbidities, diabetes mellitus was the worst hit comorbid condition during this pandemic. The moment we started with steroids in these patients with moderate to severe disease, their glycemic control went through the roof. So most of the times it was we needed to start with insulin therapy in these patients. Then because of the involvement of lung in COVID infection, the chronic respiratory disease also had deterioration or exacerbation of multiple episodes of respiratory disorders. In addition, we also had a epidemic of mucormycosis. So we had cases which we hadn't, number of cases of mucormycosis which we hadn't seen in last 10 years. So most common comorbidity associated with mucormycosis was diabetes mellitus, and we had an extensive invasive mucormycosis. So rhinocerebellar as well as rhino-orbital mucormycosis was there, and other secondary infections were also of concern, but managed according to their individual protocols. This is in short related to the infections management or clinical management. So it doesn't end here. So this is the part of secondary prevention of any disease. So the most important part of controlling any pandemic is related to the control of infection as a whole. So we need some containment strategies. So how can we contain this pandemic? So first is, the most important is awareness of this disease. So like in previous presentation, someone asked how can we control or prevent deaths in uneducated people. So this is the way to create awareness, utilize all the facilities which are available to create awareness among citizens of our country regarding this infection, the mode of its infection, and the modes to prevent the infection. So social distancing or physical distancing is going to be a new normal for our future. Use of masks, adequate hygiene with proper hand washing, repeated sanitization are going to be important in future to control this pandemic. Then early detection of cases of COVID with isolation and management of infected patients and preventing further spread to their contacts is important. Last but not the least, and the most important will be the vaccination. This should be driven, or we should achieve an extensive vaccination to achieve herd immunity. So what are the steps taken by Government of India? There were several initiatives taken by Government of India. So these are certain guidelines to effectively control COVID-19 infection. These are circulated to all the departments and all the media personnel to spread this. These have regularly updated guidelines for effective control of COVID-19. Next important step was COVID vaccination in India.
So sorry, Dr. Akil, you still have 10 minutes left for your talk.
Yes. Okay. So it's sufficient, sir.
Okay, you may continue.
Okay. So COVID vaccination in India, the first step was to development of a COVID app. This is a national level app which is linked to Aadhaar number, that is unique identification number for citizens of India. So this app was developed for vaccination purpose primarily. So on this app, usually the citizens of India are supposed to register themselves with their Aadhaar number, and they have to get the appointment for vaccination. The vaccination which are commonly available in India are Covishield, which is in India, it is developed by Serum Institute of India. This is similar to AstraZeneca vaccine. Then Covaxin is developed by Bharat Biotech in India. Sputnik V is developed by Gamaleya Institute of Russia, and it has a collaboration with Dr. Reddy's laboratories in India for production of that vaccine in India. So Covaxin and Covishield, these are usually being given under the vaccination planning by Government of India. So Sputnik V is given in private setup. Another step was to bust the all myths related to vaccination. There was apprehension regarding vaccination, its effectivity, then complications related to vaccination. So government had to take multiple steps to bust these myths. The important step was to start with vaccination in pregnancy. It's a special situation. Another vaccination strategy which has been utilized is to vaccinate the children. So there are trials going on in India for vaccination of children between 12 to 18 years of age. This is the dashboard entry of that CoWIN app, which shows all the statistical findings or number of cases of COVID vaccine. So these are the total number of vaccination doses given. So it is more than 70 crore vaccination doses have been given till date. So on 7th of September, the day before yesterday, we had vaccinated more than 78 lakh people for COVID vaccination. This gives the total samples tested till date, that is more than 53 crore. These are the samples tested on 7th of September, that is 17 lakh samples. This is the total number of cases till date with a single day increase of 37,000 on 7th of September. These are number of discharge cases. Total number of deaths is 4.41 lakh, and we have an active cases of approximately 4 lakh cases in India as per the data on 8th September. Along with that, there is also going genomic surveillance for SARS-CoV-2, because there were many different strains that were developing as the disease is progressing. So it's a viral infection. It is bound to have genetic changes as it progresses. So we have set up 10 labs or hubs for detection of or genomic sequencing of this virus. Then there are 18 satellite labs which feed these 10 hubs for genomic surveillance. And recently we had news that we have a newer strain like mu strain. Previously we had delta plus strains. Now we have a new strain. So new strain is developing. We don't know how it is going to affect management or infection or complications. So this is another initiative. So Government of India has developed an actionable toolkit to support COVID appropriate behavior and vaccination drive in India. So this is directed towards the utilization of youth, which is the huge force for managing such pandemics. So we require younger people to come in front and aid the government to achieve a sustainable and good practice to prevent and control this pandemic. So at the end, take home message will be COVID is bad luck for whole humankind. We cannot do anything about it right now. So what is in the past is done. We need to stand united to fight this pandemic. Social and physical distancing will help break the chain of infection. Vaccination should be our next step to vaccination coverage should be done to achieve herd immunity, and that is going to help us control this pandemic. These are certain references. So thank you and wish you a healthy COVID-free life. I am free for any questions if anyone has.
Okay, thank you very much for Dr. Akhil Patil with your nice information, nice presentation regarding to clinical management of COVID-19 in India. So I have questions for this topic actually regarding to your presentation that you state there is ivermectin, actually. Ivermectin in India used for mild severe. Ivermectin, we know in Indonesia, this drug is still controversial, but maybe you can give in another side, maybe. How do you think of ivermectin itself? Come on.
So ivermectin is primarily anti-helminthic drug, actually, but it is utilized in this condition as an investigational therapy. So there were hypothetical evidences of it acting as an anti-inflammatory agent. So hydroxychloroquine and ivermectin are used as an anti-inflammatory immunomodulatory therapy in cases of COVID, in mild cases only.
Okay, so it is only cases. Only for mild condition, not for moderate, severe. No, only for mild.
Only
for the beginning.
Only mild conditions.
Okay, for mild condition. Okay, thank you for
when
your.
There was no drug available initially, so we had only hydroxychloroquine as the first line of therapy.
Yeah, we have been familiar with the drug.
Yeah. There were controversies regarding its use, but we are very comfortable with using this drug in mild cases.
Yeah, I see. So maybe there will be questions. I want to accommodate the questions if we have questions from the chat. Oh no, maybe my friend, because it is a really clinical management. I suppose that my friends from Malahayati University, especially from medical faculty, can give like questions or maybe view regarding to your presentation. Hello, Dr. Sri. Do you stay there? Dr. Sri Maria, hello. Or maybe another participant wanted to give a question to our keynote speaker today. Miss Nani, maybe. Hello, Miss Nani Sarimurni. Okay, talking about vaccination, Dr. Akil.
Yes,
how do you think of vaccination in India? I mean, with the vaccination produced by India, because in Indonesia until today we haven't produced yet about vaccines which legalized by World Organization.
So we already have major institutes like Serum Institute of India. This institute is usually associated with production of multiple vaccines. So majority of no. Serum Institute of India.
Oh yes,
CSI. So it is associated with this institute is associated with production of multiple vaccines in past as well. So this was. We took some time, but this institute came up with the vaccine, which was comparable with that vaccine that is produced by AstraZeneca company. So initially we had some obstructions and hiccups while production of this vaccine, but now vaccine production is a smooth process right now. We have adequate vaccination or doses of vaccination available for vaccination. So that's why we are able to achieve vaccination in millions now. Daily, we are vaccinating millions of people in India.
Yeah, I see.
The vaccination process has been smoothened because of the app that was developed. It is very well-functioning app. So there are not many negatives about this app. So it's a simple process. You need to have your Aadhaar number for registration. If you don't have technical expertise to achieve or do registration, that registration is available at vaccination center as well.
Number pun. Only giving number pun, or
mobile phone,
and
Aadhaar number.
Easier.
Aadhaar number is unique identification number.
Easy identification such as passport. Yeah, I see.
Yeah.
Easier.
Yeah, it's an easier process.
Yeah, easier procedure.
Yeah.
Okay, maybe Dr. Sri stay on your screen. Hello, Dr. Sri Maria. Maybe you have a question regarding to clinical management of COVID-19. Hello. Okay.
Sorry, Mister.
Yes, come on, Dr. Sri, join with us.
Maybe sharing about the variant of COVID in India. We many familiar with variant Delta. Can you sharing about how much or how the clinical incidents in India?
So Delta virus appeared in India in second wave. So from March 2020 onwards, we had this Delta virus or Delta plus virus, which was actually presenting with more serious cases. The number of cases were not much, but the seriousness of the cases was quite high with this strain of virus. So the patients who were requiring ventilatory support or intensive care was quite high in such cases. That's why we had an increased mortality during this period. So we had a lower mortality during first wave when the disease was new to us. But when this Delta or Delta plus strain came, we had problems with the problem which we faced was the healthcare facility for managing such a huge number of critical cases.
Yes, so Delta variant is really the most dangerous, maybe can make acute respiratory distress syndrome.
Yeah.
Thank you.
Thank you, Dr. Sri Maria.
Namaste.
Yes.
In Thailand, in India.
in the still morning in India.
Oh yeah.
It's still in the morning.
Still in the morning.
Quarter to 11 now.
Okay. In this next occasion also, I will send my best regard to my friend there at SMBT, Dr. Yogesh and friends there. Hello, Dr. Yogesh. Nice for joining with us, and we have 127 participants, include us, Dr. Akhil Patil. Okay, I think that's enough for our presentation session in this conference with you, Dr. Akhil Patil. Thank you very much for your valuable and clear explanation about management, clinical management of COVID-19 in India. We suppose that it can bring many information, especially to our clinical management in Indonesia, because we know that in India, there is the second wave on May, and it is better at this condition. I know that India can solve this problem of this pandemic, and we hope together that we can pass this pandemic. And for the next time, maybe I will invite our partners from SMBT India come to Lampung, and we can meet together, or we can say hello together in Lampung.
Yes.
In Indonesia after pandemic pass, like Dr. Yogesh too. Thank you very much, Dr. Akhil Patil.
Thank you.
Good morning.
Thank you very much for inviting me. Thank you. Good morning.
Yeah. Okay, with the name of the committee of the first international conference on public health and medical science, I think that's all our presentation sessions, and I will back to my Master of Ceremony. Thank you. Good morning.
Thank you, Mr. Dr. Akhil R. Patil for the keynote speech. And now we would like to ask you to stay on your screen, because we would like to present the ceremonial gift to you.
Yeah, there will be ceremonial gift, Dr. Akhil. Yeah, we still wait for our Vice Rector too to have the ceremonial gift.
And to present the ceremonial gift, kindly be invited the Vice Rector to University of Malahayati, Dr. Harmani Harun, SE, M.A.K.
Thank you very much.
Session to keynote speaker, the Vice Rector too, as well as participant as welcome to take a position.
Thank you. Thank you.
At 1 p.m. Ladies and gentlemen, to all participants, the next session is going to start at 1 p.m.
लक्ष्मी टिम्बर होइन गोपाल भाइ चोकले चाहिँ बिल्डिङ
ब्रेक सेशन मध्ये आपण टाकायचे ना
Hutapea Mas Agung ini buat videonya. Pakai jaringan kamu mana?
Iya, gitu.
Ladies and gentlemen, the next session is going to start. Please be seated. Excellencies, participants, ladies and gentlemen, we would like to invite all presenters to deliver their presentation on parallel session. The parallel presentation session will be moderated by Ms. Lolita Sari, SKM, MKes, Ms. Vera Yuliani, Ms. Vida Wira Utami, SST, Danti Maternity, SST, MKep, Dr. Sri Maria Puji Lestari, MPD KED, Teguh Pribadi SKep, Teguh Pribadi SKep Nurse, MS, and Mr. Slamet Widodo, MKes. Ladies and gentlemen, please welcome all presenters, all moderators on parallel paper presentation session.
Enggak, nggak kelihatan. Ini kan kamu ya? Bukan, belum.